It's my honor today to welcome Dr. Dalal to share with us her insights on school assignments for children with neurodiversities. Dr. Dalal, developmental and behavioral pediatrics from United States, and she is active member of Society of Developmental and Behavioral Pediatricians. Thank you, Dr. Dalal, to join us today.
Today, I'll be talking about school assignment for children with neurodiversities. This is it's quite a complex topic, but a really important one that I think not just in the world of developmental and behavioral pediatrics, but in the world of just general pediatrics and all other specialties, it's important to know where kids or what options kids have when they do get diagnosed with neurodiversities or any form of disability, and what options they have for schooling. So having just some general background on where you can guide families, and not necessarily details into where they need to go, but just kind of an outline of what options they have would be very, very useful in daily practice for pediatricians. So members involved in decision making. So for children with any form of neurodiversities or disabilities, when we make a decision or an informed decision about where the child ends up going to school or what kind of classroom accommodations they have, this involves multiple team members. And it's really important to involve everyone when making this decision, because again, this is a life-altering decision for children. Not to say that it's a static decision, it is a dynamic one that you can change over time depending on how the child progresses and develops, but it's one that needs to involve the following members. So the child's family or caregivers is of key importance. We cannot be making decisions about where child goes to school without discussing with parents. Their preferences are to be taken into consideration. Not to say that that's the only factor taken into consideration, but out of respect to families and how they view their children, that decision needs to be made with them. School teachers and special ed departments and counselors, developmental and behavioral pediatricians, and this can also involve neurologists and psychiatrists. Just because the field of developmental and behavioral pediatrics can be a rare one, there's not very many of us, especially in the region we're in currently. So we actually resort to our colleagues with experience in neurology and psychiatry to help us make this decision, in addition to psychologists, speech therapists, occupational therapists, and the Board of Education, which would be in our case in Abu Dhabi ADIC. So one thing to remember that it's never black or white, and every decision with regards to where a child goes to school must be tailored to individual child's needs. So when ADIC reached out to us to collaborate with them with regards to where a child can be, or what kind of classroom or school designation goes for each child with neurodisability, my immediate response was, and they wanted kind of a category system of how to kind of where to place the child, and it's simple as ABC. My immediate response was, it's definitely not black or white. It's a process that requires a lot of thought, a lot of efforts, a lot of team members to come together and try and figure out what environment best fits this child. So it really is a challenging decision to make and requires a lot of thought and a lot of thorough evaluation. What is the importance of an appropriate classroom assignment? So why do we really care at the end of the day where the child ends up going to school? So we always say that when a flower doesn't bloom, you fix the environment in which it grows. It's not the flower. So you don't sit there and say, well, this is a child with neurodisability, let's try and change him. You give him the services he or she needs, but you need to place him in the right environment in order to thrive. At the end of the day, academic performance, overall functionality in the society and in life is kind of what we aim for. And we start off by adjusting the classroom environment or the school environment in which they're assigned to. So we ensure optimal environment for child needs to thrive. It's for academic and developmental progress. A healthy psychosocial environment. Again, we need to start exposing our neurotypical children to children with neurodiversities. It's not just a neurotypical classroom and then you have a special needs classroom for those kids with neurodiversities. Not everyone needs that. Some children do, but we need to start accepting that different is acceptable and not everyone looks, sounds, or behaves the same. Peer modeling is a huge one. So a lot of kids end up getting some form of developmental progress, especially those with social communication deficits that need the peer modeling from neurotypical children to understand what's socially acceptable. Even kids with language delays can end up having some sort of progress within their language skills by listening to their neurotypical peers and not just being at home with families who may or may not be easing the process for children. So instead of the child asking for something, that the child with language delays, he would be given what he needs because mom or dad kind of knows what he needs. So it's very, very important to have the neurotypical peer modeling. Accepting neurodiversities in mainstream schools. Different is acceptable. Letting children know from a young age, not anyone that looks different, not anyone that sounds different or acts different is wrong or someone that needs to be bullied. Again, this is another topic we need a kind of a different session on, which is bullying and trying to reduce that in children with neurodiversities. And we want to address strengths and weaknesses of every child. And this will come to in just a second. So factors to keep in mind when kind of designating classrooms or schools for children with neurodiversities or with any form of disability. I just want to make sure that this also covers children with physical disabilities. So children with cerebral palsy, children who are on wheelchairs, etc. These children also you need to keep in mind for school designation or classroom accommodations. Factors to keep in mind is the child's diagnosis. So what type of disability does this child have? Is this a child with or on the spectrum, so with autism spectrum disorder? Is this a child who has cerebral palsy, who has a physical disability, but cognitively he's intact? Is this a child who just needs some minor accommodations? He has some mild attention deficit hyperactivity disorder symptoms that need some mild accommodations within the classroom. A big thing to keep in mind when we're designating classroom and schools, child's level of functioning and independence, super, super important. Hence why it's important to have an evaluation from a psychologist. Overall IQ or cognitive level, independence level, is this child toilet trained versus is he not? Is he able to sit on his own in a classroom, pay attention, do the work that needs to be done? Or is this a child that really needs constant redirection into where kind of the classroom is or what the classroom task that's being asked of the child? So their level of independence, are they able to feed themselves independently, clothe themselves independently? And toileting is a big one to keep in mind, and I know I had mentioned that before. Cognitive abilities, like we said, overall IQ level. So we know that, for example, I'm going to give an example of children on the spectrum. It is a spectrum, autism spectrum disorder. It's no longer just autism. It's a spectrum. And therefore, you have children that are more higher functioning. You have children that are lower functioning. And how do we designate who's higher or lower functioning? Again, there are specific criteria we look at, but not an all like one size fits all kind of criteria. So children that are more cognitively able, so higher IQ, more verbal, they can get along in regular classrooms a lot better than kids with a lower IQ or kids that are not as independent with daily life skills. So adaptive skills or daily life skills, which we've touched upon. So things like getting dressed, feeding yourself, toileting, and things like that. Behavioral status or profile. Is this a child that is described by the school or a teacher as the Tasmanian devil? He doesn't sit down. He makes a mess in the school. He doesn't sit down in the classroom. What is the behavioral status of this child? Available school services and accommodations. So again, one thing to ask ourselves is, yes, we may want specific accommodations for a child or specific services, but is the school equipped to handle certain disabilities? You cannot expect a child who can't walk, a child that's in a wheelchair, to go to a school if that school doesn't accommodate for children with physical disabilities. Something as simple as a ramp to get the wheelchair up and to the classroom, ramps within the school, ramps to get into the school. So all of this kind of things need to be kept in mind. We cannot expect a child to go to a specific school if that school is not equipped to handle that specific disability. So again, that means that research into the school, speaking to teachers, speaking to counselors, principals about what the child's disability is. And this is homework that parents have to do, as well as us as developmental and behavioral pediatricians have to do before we make a school assignment for the child. So we need to go into that and try and figure out what they can or cannot accommodate in that school. And that doesn't mean there's a specific flaw in the school, but not all schools are equipped. There could be financial reasons why they're not, or that the school is not big enough to accommodate this. So going in and talking to the special ed department, talking to the principals, and getting everyone involved. So this kind of summarizes the process or the kind of the options we have for children with neurodiversities. It's quite a it's a busy slide, I understand that, but I'll try and walk you guys through this. So there's two main categories that we look at when we want to assign children to a specific school or classroom. There's the option of mainstream schooling as per training as a developmental pediatrician from the US, my training has focused on get as many people to be in a mainstream school in an inclusion classroom, reduce the stigma of neurodiversities amongst children within the classroom setting. That's kind of what we aim to do. However, we want to be realistic at the end of the day. Not everyone belongs in a regular school, a mainstream school, an inclusion classroom, and not everyone belongs in just a specialized school. But our aim is to keep as many people as we can in an inclusion classroom setting. Those that cannot, or those that are much lower functioning, not as independent, nonverbal, have major behavioral issues, then we can start considering the second option of a specialized school or a specialized center. So when we have the option of a mainstream school, this can look a couple of different ways. The first way we look at it is that is the child able to stay in an inclusion classroom? So within a main classroom, neurotypical peers with no other disabilities. So he's in the same kind of classroom as his other peers with few accommodations. Then you have one of the more common kind of classroom settings that we see and that schools resort to when they do send children to us to evaluate is being in an inclusion classroom with a shadow teacher assistant. So this is one-on-one assistance with the child. It's someone who stands next to the child or in the corner in the classroom, watching the child, making sure they stay on task, or even repeating certain tasks for the student that they're watching. So this is still within the main classroom setting. So remember, the first option was not having a shadow teacher. Second option is having a shadow teacher. And schools, a few of them that I've dealt with, will only accept a child with any neuro disability if they have a shadow teacher. And unfortunately, a lot of the times it's a challenge to find a shadow teacher. There are companies that schools work with, or parents just have to look up shadow teachers on Facebook pages, Indeed.com, and things like that, or just word of mouth to find a good shadow teacher. The other option within a mainstream school setting, so we've talked about inclusion classroom, there's two sub options to that. Another option is a self-contained classroom, and that's what we call it in the US. Over here, I've heard the term SEN, Special Education Needs Classroom. So again, we're still in the setting of a mainstream school, but right now, this is a different classroom. It's not with your neurotypical peers, so there's not that modeling kind of factor here. It's a much smaller classroom made up of 4 to 5 children, and all of those children have some form of disability. And it's not all the same. It could be a child with autism spectrum disorder, with a child with Down syndrome, with a child with major behavioral dysregulation, intellectual disability. They could have different diagnoses, but all within the same classroom of 4 to 5 children with a lot of one-on-one assistance, a lot of shadow teachers, and more than one teacher within the classroom setting. Those are, again, this is an option for our children that are a little bit lower functioning than those with higher functioning disabilities. So those are the 3 main options within the mainstream school setting. We move to the specialized school or center. So this can look a couple of different ways. It could be a specialized school. As I've gotten to know the system here a little bit over the last couple of months in the UAE, I've learned to deal with specific schools. There's a Karama school that's here for nationals, UAE nationals, within Abu Dhabi. It caters to children with autism spectrum disorder specifically. It is a specialized school, meaning that everyone that attends that school has that specific disability. Does that mean that every specialized school only sees a specific disability or neurodisability? No, this is not true. So specialized schools such as Karama, yes, they see one specific disability and it's all children with autism spectrum disorder. However, there are specialized centers that are also available for non-UAE nationals, so expats as well, and their children. Things like Future Center that see children with a wide variety of neurodisabilities. And I've had a conversation with them quite recently just to kind of see what disabilities they accept. And they accept children from the age of 3, those with autism, intellectual disability, global developmental delays. So there's a mix of disabilities. Of course, we'll get asked sort of which one is right to keep children with the same disability together or those without the same disability together. There is no right or wrong. It is each tailored to every child's needs. I prefer to keep children within the mainstream school setting, inclusion classrooms, for as long as we can, unless really by IQ and by adaptive skills scores, we are very, very low to the point that we cannot function within a classroom setting. Peer modeling is key importance within the field of developmental and behavioral pediatrics. Even if you go into kind of theories that have come about from previous psychologists way back when we started the field of developmental behavioral pediatrics, a lot of them had harped on the importance of being around children that are neurotypical. As part of normal development, we look at our peers, we look at the people around us to learn the specific developmental kind of language skills, social skills, and all of those things. So that's the importance of being within a school setting. Not to say that there isn't other kind of options here. So we talked about a specialized center, future center. There's another one, the New England Center, which is known as the Mohammed bin Rashid Center for Special Needs now. Again, not specifically just for autism, but other disabilities as well. So those are the two main categories, and then you have the subcategories. ADIC has started an initiative where it's collaborating with clinics. KidsHeart Medical Center is one of the clinics it's collaborating with, and we feel honored to be part of this because it really is, it makes a huge difference to families to have specialists that are on board to help them make this decision. As you can imagine how stressful this can be for families to make a decision about where their child ends up going to school. So they're actively designating children to their appropriate classroom environment. They're ensuring adequate academic and psychosocial development. So we talked about the importance of putting a child within the correct or the optimal classroom setting. So I want to just go back and say this for whoever wasn't on the call before. It is really not a static process. So it doesn't mean that once I place a child in this classroom or this school, he's going to remain in this development. And the beauty of childhood development is that it changes over time. Some children will make tremendous progress and will switch from a specialized school to being able to handle mainstream inclusion classrooms. Whereas in the other hand, a little bit more unfortunate is some children will regress if they don't get the services that they need. And then they need to be placed in a specialized school. So it's a dynamic process. It's constantly changing. It's why these kids need a follow-up even after diagnosis. So we always say you get the diagnosis that you get, but you need follow-up to see where you're at developmentally as you progress. What does this process look like? So again, it looks much simpler than what it is. This is a very meticulous process. It needs a lot of time, effort. It needs a lot of team members that we had talked about initially. So the school flags the child and says, hey, something's going on with this child. Not too sure what it is. We have our suspicions, but he's not moving on the same track developmentally as other students within the classroom. Or that the child is entering the school, and while they're assessing him to enter the school, they pick up on certain things and they say, we're not sure what this child has. They flag the child. ADIC gets involved as a referral process, and then ADIC, which is the Abu Dhabi Department of Education and Knowledge, then says they need to be evaluated. They'll designate a specific clinic for this child to go to. Again, we've been seeing patients from ADIC that are referred to us at KidsHeart Medical Center, who get evaluated by myself and my colleague, the other neurodevelopmental pediatrician, plus minus a neurologist or psychiatrist. Again, we need the expertise of neurologists and psychiatrists because at the end of the day, there's not many of us to go around as neurodevelopmental pediatricians. In the US, it's primarily just the neurodevelopmental pediatrician's job. However, here we do resort to our colleagues with their experience. The next step is to kind of refer them appropriately to speech therapy, occupational therapy, physical therapy if there's a physical disability, and psychology. To me, all of these specialties are important. The one that I kind of harp on the importance of more than other specialties is psychology. I really need to get that neuropsych assessment done. I need to see where the child is at cognitively, where his adaptive skills are, his independence, his level of functioning, where is he at? And then, of course, speech and OT and PT, depending on what disability the child has. We then come together as a team who have evaluated this child. We make our final recommendations. And then again, importance of discussing this with the family. You don't make a decision as a physician and as a clinician, as a team, alone without the child's family or caregivers being involved. They need to be actively involved in this process. You need to let them know what the recommendations, what you found, and where you think the child will thrive best. Get their feedback. Once all of this is done, it goes back to the school. So through ADIC goes back to the school, and they will help make the final decision. In the US, the process is a little different. It relies heavily on school recommendations. So we have the school do the evaluations, and if they need other help from us, they'll reach out to clinics to help them, but they're the ones that let us know what kind of red flags that they see, what they can accommodate, and what the school has or doesn't have for children with neuro disabilities. Every school should have a special ed department in the UAE, and so we can get in touch with them, but not every school can accommodate different neuro disabilities. So an IEP. So any pediatrician who has dealt with children with disabilities, any form of disabilities, will have come across at least a few patients, a handful of patients with an individualized education plan. So we talked about the process before. So this one right here, and we said we made recommendations. The school then, it's on them to make a decision about what kind of program they want to make for that specific child. An IEP, as per the name, individualized, is tailored to every specific child. Not everyone has the same IEP. An individualized education program. It states what your issues are, where your weaknesses are, what we want to focus on, what our goals are, when we're going to reevaluate those goals as a team. It involves the family, the teachers, the counselors, the school, and designated advocates. So if there's someone that's advocating for the family, or it could be the developmental pediatrician that's also helping make this decision. So the school has to come up with an individualized education program. It involves the progress of the child with a disability, the related services. So what is he going to get? What does that look like? How many times a week is he going to get that? So for example, if it's a child with language delays, is he going to get speech therapy? How many times a week? For how long? When are you going to reevaluate? Are you just going to say it's a language delay? No, we need to know when is the next time you're going to evaluate. So what that kind of looks like, I've given a true example of an IEP. This is for a child who attends Aldar Academies. He's in grade 9. He has a diagnosis of autism spectrum disorder. He's in an inclusion classroom setting. He did have a shadow in the past and was able to function without the shadow teacher, one-on-one assistance, made great progress. So we updated his IEP, his individualized education program. So what they did was they said what his areas of concern are, if you can see on the screen, and the areas of strength. Then they went down to the areas of concern. I'm just going to read through this to give you guys an example of what this looks like. So if it comes across in your clinics or patients come to you and have an IEP on hand, this is kind of how you look at this. You look at the area of concern. So he had some issues with reading and listening comprehension. Their target or their goal is to be able to understand the task set and give it a try independently. That's what they want to do. They want to get that goal. And their outcome is for him to be able to make a start on tasks following instructions he has been given. So in the past, he had difficulty staying on task, especially for non-preferred activities, which is academic activities. And he did have some rigid behaviors, some repetitive behaviors. So they want to see if he can follow instructions as given on his known. What are they going to do? So you can't just give me a goal as a child and tell me this is what I want you to do. There needs to be a strategy. So what is this classroom going to do for him? They're going to pull him out for reading or listening interventions, for one-on-one services, 15 minutes, 2 times weekly. So this is very specific, and that's what we want to see on an IEP. I don't want you writing, I want him to do some reading and listening. That's not sufficient. I need to know for how long, and I want to know when you're going to reevaluate. Go back up. The start date, this was the 27th of September, 2022. When are you going to review? In about 6 months, they said. The 16th of January, 2023. What happens at the review date? Parents come in, the child comes in, the teachers come in. We all decide together. What's happening with this child? Is he reaching the goal? Is he reaching the target? Are you using visual aids to support listening? Is an adult checking in on him? What's going on? Who can we report to? Key staff members, the inclusion specialists. So this is what an IEP kind of looks like. And they go on to talk about the different areas of concern, their goals, their strategies. If he's not meeting those goals, what could we be doing differently? Then the process starts again. Should we be intensifying his services? Is the reading or listening intervention one-on-one for 15 minutes? Is that not enough? Do we need to bump that up to 30 minutes? What's going on? Is there another learning disorder? Is there a reevaluation that needs to be done? So again, a very nice dynamic process. And the IEP goes on. It could be about 3 to 4 pages long. In the US, it's about 30 pages long. So I really appreciate in the UAE that it's concise and precise. It's 2 to 3 pages long. Just more specifically, children with autism spectrum disorder. This is kind of one of the main referrals for patients that come to see me, those with speech delay and end up with a autism spectrum disorder diagnosis. And just to go through the criteria for autism spectrum disorder, one major change has been made when we look at the DSM criteria for what we look at to diagnose autism spectrum disorder. If you look back at the DSM-4, which is now updated to the DSM-5, previously they had divided autism, mind you, the word autism, and it wasn't just specified as a spectrum, autism into 5 distinct diagnoses ranging from Asperger's syndrome, a term that we no longer use. We've abandoned the term Asperger's syndrome, which was used to describe mild or high functioning autism. we've replaced Asperger's syndrome with high functioning autism spectrum disorder. And then their lowest level in the DSM-5 was autistic disorder. This indicated severe autism. The DSM-5 then came along and said, hey, no, I don't really think this is 5 distinct diagnoses, which I agree upon, because once you see one child with autism spectrum disorder, you've only seen one child. Every child has different strengths and weaknesses. The spectrum itself is fascinating to look at. And every child that comes in to see me that I diagnose with autism is just a fresh face. It's mind-boggling to me just how different they are when you look into specific details. Yes, the baseline criteria we look at are the same, but every child, when you look at him just as a whole, is very, very, very different. So the DSM-5 said no more of this 5 different categories. Everything will be under the umbrella of one single diagnosis of autism spectrum disorder. But they said they will have different levels of severity. How do we know what the different levels of severity are? The DSM-5 then went on to say, we're going to agree upon different levels of support to help families when they want to get children into the school. They said that there's 3 functional levels for autism spectrum disorder, level 1, 2, and 3. I wish it was black and white. Again, I wish there was a box where I could say you're level 1, you're level 2, you're level 3. It would make life much easier. However, it is really not this way in reality. So when you're talking about children with autism spectrum disorder, level 1, again, when we talk about levels, we're not talking about just severity. We're talking about levels of support that the child needs. We look at a lot of other factors when we're talking about different severity of autism spectrum disorder, which is why when parents come in with the question of, can you give me a percentage of how autistic my child is it 20? Is it 30? I always tell them, I wish I could give you a number, but it's really not like that. I would say, for example, Hussein or Zayed, he has strengths in that he is verbal. He's able to communicate. He has weaknesses in that he's not as social as his other peers. So we focus on strengths and weaknesses. But going back to the DSM-5, they said, let's talk about levels of support. So they said level 1. This child requires some support. So this is a very high functioning child that really could do well within a mainstream school, within an inclusion setting. They said this is a child with high functioning autism, so previously known as Asperger's, which we don't use anymore. He has a hard time communicating appropriately with others, so they may not say the right thing at the right time, or not know that what they said is inappropriate to say in front of other people. So these are the kids that parents will come along and say, my child has no filter. So typically when they say my child has no filter, it's that socially they're not saying the appropriate things. They're not able to read social cues or body language. So basic things, just like I talk, you listen, then you talk and I listen. The things that we take for granted as adults that don't have any social communication difficulties, these children do have. So they need to have social skills training. The body language, reading that someone's face looks annoyed, angry, for you to stop doing what you're doing. They can't read that as easily as we can. They're usually able to speak in full sentences and communicate, which is why high functioning autism, children with high functioning autism will usually come at a later age than those that are lower functioning. They can speak in full sentences and communicate, but the pragmatics, the social portion of their speech is just not right. They can come up as the kids that are quirky, the kids that are socially just not right. And those are the kids that get referred. They may try to make friends and they may want to make friends, but may not be very successful. These are the kids that are prone to bullying as well. So they require just some support. These are the kids that might do well within an inclusion classroom. Level 2, they said this is the next step. These are the kids that require substantial support. They have more prominent problems than level 1, than children with level 1 supports. They find it harder to change focus or move from one activity to the next. What does this mean? This means that we know that rigidity and sticking to a routine is common amongst children with autism spectrum disorder. They found that these children that need more substantial support, it's very, very difficult to transition their attention from a preferred activity, like I like to sit and line up cars. I like to sit and spin the wheels of something specific. Now you want me to do something academic, to shift my attention from a preferred activity, lining up my cars, to taking my cars away and telling me, let's do my ABCs. That's someone that would fit under this kind of category. They have narrow interests and engage in more repetitive behaviors. Again, repetitive behaviors like hand flapping, rocking, spinning. These are not wrong behaviors. They may be socially unacceptable to people, but we need to spread the word that if this is the way this child soothes himself, is to flap his hands, that's not a reason to put him on medication and to target him that's really not the reason. If he soothes himself by flapping, let him flap. Let him flap, and maybe he'll focus a little bit more within the classroom setting. And they struggle with some nonverbal communication. They do speak in simpler sentences than those with level 1 support. Level 3, this is the most substantial or the most severe of all the 3 levels. Typically, these are children that are nonverbal or only slightly verbal. They'll speak in single words, shorter phrases. They require the most support. These are the children that typically will thrive best within a specialized school setting or a specialized center where they can receive their services, ABA therapies, speech therapies, occupational therapies, all in one place. They have problems expressing themselves both verbally and non-verbally, and can make it very hard to function. Remember, these are the kids that are probably not as independent as their peers within the same spectrum. So it's an 8-year-old, one is high functioning, one is lower functioning, one is toilet trained, one is not, one can dress himself, one is not. They're both on the spectrum, but one is higher functioning than the other. They engage in more repetitive behaviors that can consume a lot of their day compared to others. So what are the limitations? Again, like I said, I wish it was an all white, all black system where I know where you belong, what school you belong. I'll put you in this box, level 1, level 2, level 3. It's definitely not how this works. Why? The limitations of the ASD levels, which is why even in the US per training, we don't even mention their level unless really, we want to make a school recommendation. We'll put it into our evaluations as part of our objective kind of data that we want to give, but we don't say this is level 3, this child needs to go do this, that. We say put it into the setting of the clinical picture that we see, and maybe this will help guide to which classroom or supports that he needs. So the limitations of level 1, 2, and 3 as the DSM-5 criteria, they said it didn't give a full picture of the strengths and limitations of each level. So that's something I've been talking about repeatedly, is that it really doesn't give the full picture about the child. They're not entirely inclusive of all symptoms and needs of all people with autism. There's a level a person is assigned when they're first diagnosed. So remember, I said when you're assigned a specific level or a specific classroom initially, there's 2 ways you can go. You can either deviate negatively or positively. You can make developmental progress and end up in a mainstream school, in inclusion classroom, plus or minus a shadow teacher, or you can regress and you'll need to go to a specialized school or center. It doesn't predict or account for unique details in the personality and behavior. There needs to be a behavioral assessment of this child, even if he's higher functioning. If he's a child who has comorbid ADHD, major behavioral issues, what does that kind of look like within the classroom setting? So he could be very high functioning, but he's not functioning within an inclusion classroom setting because he's so destructive to his environment. So services they receive will need to be highly individualized. It's not an easy process. It really is not a yes or no. This is where the child belongs, or this is not where he belongs. So just a quick touch upon accommodations for children with ADHD. This is something that we used to call in America was the 504 plan. So these are kids that don't necessarily need an individualized education program or plan. They need some accommodations within the classroom setting. They're otherwise verbal, independent, they're fine, but they need some help paying attention or staying in place. They can be very fidgety. They can be children that just can't sit in their seat, continue to talk, always get in trouble. What do we do for those kids? Maybe they don't need a full-blown IEP like we talked about. Maybe they need just a few classroom accommodations. This can be easy, things just like seating the child at the front and center rather than putting that child with attention issues all the way at the back. Limiting his access to other children. So children with defiance and children with inattention hyperactivity tend to gravitate in general as part of the social norms towards other children that are defiant, AKA the class clown, or someone that really comes off as funny, but they're actually defiant. So children will tend to gravitate towards those. They'll want to choose seats where there's another child that's making problems. What teachers can do is say, okay, now I've realized that this child has a problem with attention, defiance, etc. I'm going to bring him to the front of the class. I'm going to make sure that the person sitting by him is a child who's well behaved, to look as a role model for this child. We can increase the distance between desks if possible, again, if the classroom is large enough. Younger students, what we used to do in the US, we mark a tape around the desk where they can move freely. They have those movement breaks, because if you can wiggle that a little bit of inattention and hyperactivity out of yourself in order to stay on task every 15 minutes or so, well and good. That's your accommodation. Then you can sit back down. Allow extra time to complete assigned work. We used to do this a lot for our kids that are in high school or that are in elementary school. We give them 10 to 15 minutes more time to finish their classroom work. break long assignments into smaller segments, pair written instructions with oral instructions. Don't expect a child that's not paying attention to you for you to say, well, we're going to do pages 1 to 5 today. We're going to write 2 paragraphs each, and we're going to talk about how we're feeling. He's probably stopped paying attention the minute you said we're going to, and then that's it. It just stopped there. So instead of just oral instructions, write it down. Check in with the child, make sure they understood. And it doesn't have to be something as obvious as, Ahmed, did you understand what I just said? That leads to social stigma between the students. Take the child aside after the class has been completed, or the session is over, the subject is over. Take him aside, say, Ahmed, was that clear? What I just said, was it clear? Can you show me what you understood? Can we write it down together to make sure that you understood the task that we're going to do? Do you need help with this? So frequently checking in. And again, avoiding the screaming out loud at the child, you're not acting right, you're not doing this right. Take the child aside, reduce the social stigma associated with neurodiversities. You can set a timer, 10 minutes intervals, and have the student get up and show the teacher their work. Again, or the teacher can check in, which can be less kind of embarrassing for children, especially those that are in high school. So key points out of all the stuff that I've kind of talked about is that we need to assess each child individually, not a one size fits all approach. That doesn't exist. I feel like that doesn't exist for anything with within the world of developmental and behavioral pediatrics. If it did, our job would be much easier. But I think that's what's fascinating about the field, not to be biased towards our field, but I feel like it's one of the ones that is continuously changing. Our guidelines are continuously changing. Our diagnostic approach is changing. Each subspecialty needs to assess the child and be a part of the decision making prior to designating final school assignments. So it's not a one person. And again, the importance of involving family members when making that decision and involving the school. Caregivers, parents play a vital role, and the child's cognitive skills, adaptive skills, behavioral status, nonverbal and verbal communication skills, and social skills are key. So these are kind of the stuff we look at when making classroom assignments or school assignment for the child. And then trying to figure out where the child thrives best and making sure they're in a quite a good environment for them to thrive. If not, again, there's room for reevaluation. There's room for this to be a dynamic process for people to be on board with. And that's kind of it. So I think if anyone has questions, feel free to unmute yourself, or if you want to write it within the chat box, that's also fine.
Thank you, Dalal, for this beautiful, really beautiful. It enlightened me, it amazed me, it made me think about changing my own specialty to be a neurodevelopment doctor. You just go, I was thinking when they say it took a village to raise a child, it seems like it took the whole city and sometimes maybe the whole country. I'm amazed that you already changed the name. Before, when you do a lecture, you was saying Timothy, John. Now you are saying Zayed and Ahmad. So we are making a true progress in this area. And thank you very much. What I will say, how the school, we don't, we can't really compare ourselves to the outside world. We are who we are, and we are growing fast. And we know the UAE government recently and throughout the last few years have been pushing for more, what they call it, people of determination to be integrated into the community. One of the main challenge I found it from schools as a father or as a health provider, the school look for more clear guidance, more clear guidance. The child come to you, you evaluate, you make a good diagnosis, you make that, you make a few recommendations. Sometimes the recommendation is not good enough for them because they lack the whole spectrum. You're assuming that they have a good social worker, they have a good psychologist, they have speech, they may not have all of this. They have one person who usually gets scattered, I'm talking from experience, gets scattered between different children, try to give the support. This is 30 minutes, this is 1 minute, this is 1 hour, this is, and the dilemma keep going inside the school. And then that's one thing. The other thing is the role of APA in the school setting. These people are professionally important, but they are expensive to assign them for a specific class, for a specific school. And then the third thing is that the teacher that you may include inside the class, not all of them, because if I am paying as a father, because these are not paid by the government nor paid by the school. So if I am paying for the father for a shadow teacher, that's mean I'm talking about 5,000, and that's a lot of money. But with 5,000 is not going to buy me a specialized teacher in this area. You are assigning a teacher to give you the most important job in the world to somebody who's not prepared. Or you want to go to 20,000 or 15,000 or something like that, and then you cannot afford it. How can I tackle all of these issues?
So that's a really good question. I feel like there's a lot that goes into this. That's the thing. So as I'm recently familiarizing myself with kind of what services are available, I've had so many parents come to me with the same questions that you have, the same challenges. So services can get very, very expensive in the UAE. So compared to the US, where it's your right to ask for these things and things are covered, in the UAE, it's very, very expensive, as Dr. Suleiman had mentioned. So figuring out which school. So this is why we always say when we make the decision, we reach out to the schools directly to reach out to us as clinicians, as the team, to ask them directly, do you have these accommodations? So asking them truly, and hopefully they will answer us transparently, which I haven't really gotten so far. They're not as transparent because they don't want, especially in private schools, they really don't want these families to go somewhere else. That means you're losing out on business, you're losing out on children that could be giving you a little bit more business. But what I would say is, it's come to my attention that there are specific schools. I won't disclose this obviously over this lecture, but there are specific schools that I've dealt with as a developmental pediatrician that seem to know what they're doing. So it's a handful of schools that, based on what I'm hearing from parents, they're bringing me the IEP, they're having teachers, and teachers have reached out to me directly. There's a handful of schools that I would say really do know what they are doing. Are they cheap schools? No, they are extremely expensive schools. They are private schools, American system, British systems, etc. So it's really it's a meticulous process. You really have to try and figure out which school is doing what. And even if they won't disclose it, I feel that families, as they follow up, again, the importance of following up with your pediatrician, your developmental pediatrician, they'll come to you and say, you know, I don't feel that I'm getting any feedback from teacher A, B, or C. I don't think this speech is happening, even because as the child gets older, even will say, I didn't attend a speech session today, especially the higher functioning kids. They give us insight into what's happening at school. Even when I'm having a conversation with parents, I'd say, oh, it looks like he's having speech 30 minutes a day. The child, the 8-year-old or the 9-year-old will look at me. Speech, no, I haven't seen Miss Kate or etc. in weeks. And the mom will turn around and say, why? She left, she was on sick leave. So again, it's kind of figuring out who's there and who's not there. The other thing is about ABA and whether ABA should be done in school or not. One of the newer trends that I've seen is an ABA trained shadow teacher. They're the rarer kind of shadow teachers. They're the more expensive shadow teachers, but I've seen parents who are highly educated about what their child's condition is and saying, I want an ABA shadow teacher. And I say, you know, there's probably a handful of those in the UAE, but they are available online. They've, you know, I've tried to link with people on LinkedIn to see who are hiring, who's not, with regards to BCBAs who are shadow teachers, also to link families to that. But again, it's a very, very difficult process. I think we still have a long way to go. Dr. Sleiman, you mentioned a lot of like the things like, how do we know, and how did, if the schools know, go back, I would say even 5 or 10 years ago, I don't even think an IEP existed. I don't think children with neurodisabilities were even included. I mean, it's only recently within the last, I want to say, well, in the US since like 1975, 1980s, but more recently here that we've started to include these children within the school setting. So I don't blame the schools fully for not being fully equipped or understanding. It can be very intimidating whenever you get a child with a diagnosis. It kind of seems like no one wants to touch that child. No one wants to deal with that child. It's extra work for all the school. But again, I feel as human rights and as children's rights progress, teachers will have to start expecting that you will have at least 1 or 2 children within your classroom that are not your neurotypical child. We still have a very long way to go. You know, these answers, I feel probably in a few years we'll have more solid, concrete answers. But for now, I think it's everyone trying to do their best with what they have. But it takes a lot of investigating and research to figure out who's getting what services at school, and truly, if they're getting it or not. And it takes literally me reaching out to the school, trying to talk to the teacher and figure out from her what's going on. Is she really bothered by this? Is she educated enough to take care of this, or does she needs extra help? Then she needs to talk to us, and we need to try and see where we can get extra help from.
I'm sorry, I cannot help it. A couple of points, very important point that I will ask for you. There is two dilemma that I've seen it through, I'm not a child development guy, but I see what is going on around the center because we are working in this center. Two major issue. One of them, one parent will complain that the school rules does not allow father or mother to talk to the teacher. So you take the teacher from the front, you leave him in the front, and no visit, no communication, nothing. And I want to understand what's your specific advice to these schools. What is right, what is wrong? That's number one. The second other way around it is parents come to us in the center here and asking, please, I don't want you to write the word autism because I am gonna, first, my social security will go weary. In the future, everybody will find his diagnosis and they will not think this is a high functioning person. Children will, bully him and say he is this, he is that. How do you how do you deal with that and still give the message that to take care of this child? Thank you.
Both really good questions and quite challenging questions. So your first point about so whether schools direct communication with teachers. So I found that there's a couple of different ways. So sometimes the parents don't want to speak to the teacher, like you said, they don't want to put that label on them. So there's that kind of thing to deal with. Other times where you say the teacher doesn't want to talk to the parents have the full right, is what I realized from majority of schools, to reach out and speak to the teacher. There should not be a reason why that teacher won't speak to the school, to the parents. The other thing is I've compiled for KidsHeart Medical Center, I have my own teacher report form. It goes from 0 to 5 years of age and 6+. So they're two different forms. This form doesn't really have anything about a neurodisability on it. It basically just says, hey, I'm this physician from KidsHeart Medical Center. I need to collect information about this child, his behaviors, his level of attention, just how he's doing within the classroom setting. What I've seen surprisingly is that teachers have been very, very cooperative. They'll fill it out, send it back with the parents, again, with their permission. So I've been able to figure out what's going on in the classroom setting just through that, through a teacher report form. So if they won't say it directly to the parents, they'll say it to the physician or the clinician. But I always tell parents, get involved with your child's school. If the teacher won't escalate it to the principal, figure out what's happening at the child's school. Push it, definitely. You have the right to speak with whoever's looking after your child, whoever's educating your child. If there's a shadow teacher, you need to know she's doing her job. Unfortunately, more recently, there was a case that came along that mom would drop the child off. The shadow teacher would be on her phone the whole time. The severely autistic child who's very low functioning is sitting on the swings for 6 hours, and the shadow teacher's on her phone, and mom has video evidence of this. So again, I'm not saying spy on what's going on with your child, but ask, be an active process, be an active member of this kind of team. And you have the right, just like you have the right to a report from a doctor, you have the right to a report from the school to speak directly to these teachers. The other point is your point about social stigma. I think, so this is one of the challenges that I face very much here in the UAE since transitioning back from the US. It definitely is a very different patient population. People are more afraid of us making the diagnosis. So the way I approach this is a couple of different ways. I say that every school has a special ed department, which means they do expect legally and ethically to have children with special needs. They don't have the right by law to discriminate. You can discriminate in your mind, but you can't say it out loud. You can't show it. You can't say anything. Should you show it or verbalize it to a parent, the parent has the right to take you to court. Because as a special ed department, this is what you should be doing, accepting. They're transparent. They'll say, we accept X number of students with special needs. That's what they can do. But they can't say, I refuse you due to your special needs. They can say, for example, they're not thriving in this classroom environment. What else can we do? But we need to give another option to the parent. They're not responsible for telling you where to go exactly, but they refer you to us for us to help you, to tell you where to go. What I usually tell parents is a label we don't slap on a label and say, that's what you are. You have autism and I'm just here to do my job and give you a label. I always say, I give a label or a diagnosis in order for you to get services that you need. If you have a diagnosis, it's much easier to get services, convincing services, good services, and services that are pretty much not all covered, but you can get a lot more covered if you have a diagnosis than if you don't. We all know this working in a private clinic. If you have a diagnosis, we send to the insurance will cover you. This is the same way. If you have specific diagnosis, not all, but it'll help you with services. It'll help you with that. So I always say it's not the label just for the sake of a label. The label is there to help you get the services that you need. Teachers in schools should be aware of what the child has. It's not fair. It's really not fair for both, for the student and for the teacher. The teacher needs to know that if this child is not socially interactive, you don't leave him in the corner to flap his hands. You need to actively engage this child to be with the other students. She needs to know there's a specific, he or she needs to know there's a specific issue happening, and this is what we're doing. You can accommodate, or you feel like he's not doing well in the classroom, let us know. Let us see if there's other backup options. But transparency with communication is key. I think that's kind of where we get to with all your questions. I do. I do. Because ethically and medically, again, as a medical professional, as someone who vowed to do no harm at the beginning of my medical training, that I'm harming the child by not putting that diagnosis. It's unethical. It's up to the parents to, however, to take that report and share it with the school. I don't have the right, like I do in the US, to send it to the school by law. By law here, I'm not. They take the report, and I usually give them 2 reports. I say, this is yours. This is for the school. Should you decide to share this with the school? However, I don't have the right to give this to the school. So don't worry. From my end, I'm not going to disclose of everything. But in my report, it says this and that. And that's why, again, as professionals, we don't just give the report and say, have a good day. I walk through every single thing that's written on there. You don't want surprises for the parents. You don't want to surprise them with a diagnosis or something that they don't agree with or they don't see. And you want to give them the option to share it with the school. I always say, I highly recommend to share this with the school because A, B, C, and I give them all the reasons why they should and the services that we need to work on, and that the school should understand what's going on with the child rather than be lost. But again, you have parents that will take my advice and other parents that will keep that second report to themselves. That's up to them at the end of the day. But for me, it's kind of giving the guidance for the child.
So thank you, Dr. Dalal, for this rich and informative speech. Thank you, everyone, to join us. Looking to see you next time, inshallah.